Welcome to our channel. Today, we are delving into a common yet often misunderstood topic: zygapophyseal joint pain. These joints, also known as facet joints, play a crucial role in our spine's movement and stability. However, when they become painful, it can severely impact our daily lives. Let's dive in and learn more, starting with the anatomy of zygapophyseal joints.
Facet joints are symmetrical synovial line joints between a fibrous capsule that connect the articular facets of the vertebrae. The superior facet of the lower vertebrae articulates with the inferior facet of the vertebrae above. The facet joints are situated between the pedicle and lamina of the same vertebrae and form the articular pillars that act to provide structural stability to the vertebral column as a whole. The functional unit of the vertebral column consists of two adjacent vertebral bodies and intervertebral disc and two facet joints. This unit is called the motion segment. The posterior portion of spinal motion segment guides spinal movement, with the type of motion determined by the plane of facet articulation. The coronal orientation of the thoracic facet joints minimizes extension but allows rotation, while the sagittal oblique orientation of the lumbar articular facets minimizes rotation. The posterior portion of the motion segment contains the posterior ligamentous complex, which plays a critical stabilization role. The posterior ligamentous complex, composed of the supraspinous ligament, interspinous ligament, articular facet capsules, and ligamentum flavum. Broadly, the facet joint is made up of a variety of hard and soft tissues. The synovium, which is a connective tissue lining that maintains lubrication for the articular surfaces and enables their frictionless motion, and a ligamentous capsule that envelopes the entire joint. The bony articular pillars support compressive loads, and the facet capsular ligament resists tensile force that are developed across the joint when it undergoes rotation and translations. Together, this collection of tissues function to transfer the different loads across the joint during a variety of loading modes for the spine. Chronic pain problems can be attributed to pain that emanates from different structures of the spine. The studies estimated the prevalence of spinal pain in the general population as 66%, with 44% of patients reporting pain in the cervical region, 56% in the lumbar region, and 15% in the thoracic region. The facet or Zygapophyseal joints of the spine are well innervated by the medial branches of the dorsal rami. Facet joints have been shown capable of causing pain in the neck, upper and mid-back, and low back, with pain referred to the head or upper extremity, chest wall, and lower extremity. The function of these joints is to allow for flexion and extension of the spine while limiting rotation and preventing the vertebrae from slipping over each other. Facet joint disease, also known as facet syndrome, is a condition in which these joints become a source of pain. Facet joint disease is often caused by spinal degeneration or spondylosis. Joint degeneration that occurs as a result of natural wear and abnormal body mechanics is called osteoarthritis. Facet joint disease can also be caused by trauma caused by injury or sports activities. Inflammatory conditions such as rheumatoid arthritis and ankylosing spondylitis may also contribute because of inflammation of the synovium. Facet joint disease can develop as a result of facet joint subluxation caused by spondylolisthesis. Those with facet joint disease show signs of cartilage erosion and inflammation, which can lead to pain. The body will also undergo several physical changes in response to this process. Ligaments, such as the ligamentum flavum, can become thickened and hypertrophic. New bone formation around the joint can occur with the development of osteophytes or bone spurs. There can also be an increase in the subchondral bone volume with hypomineralization. The prevalence of facet joint disease suggests that degeneration is the main cause, as it is often affected by the elderly population. However, facet joint arthritis is more likely to develop if you have a history of heavy work before age 20. Obesity is a major contributor to osteoarthritis. Consequently, it is a likely contributor to the development of facet joint disease. Whiplash injuries have a prevalence rate of 29% to 60% of cervical facet disease and pain. Facet joint disease is often a clinical diagnosis, and therefore the history and physical exam are extremely important. Facet-mediated pain is typically non-radicular. Patients frequently describe the pain as being worse in the morning upon waking up or during times of inactivity. The pain may also intensify with spine extension, facet joint palpation, and rotatory trunk motion. Facet joint palpation and axial loading can also elicit pain. Reproducing the patient's pain with Kemp's maneuver, rotation, lateral bending, and back extension suggests facet joint disease and arthropathy. Isolating facet joint disease as the sole cause of a patient's neck or back pain is often challenging. Imaging techniques such as X-ray, CT scan, and MRI have limited diagnostic validity. They may reveal degeneration, joint space narrowing, facet joint hypertrophy, joint space calcification, and osteophytes. However, these findings can be present in both symptomatic and asymptomatic patients. Diagnostic medial branch blocks are considered the gold standard approach to diagnose facet joint pain. Conservative management is the first-line therapy for treating facet-mediated pain. Management is typically multimodal, consisting of education, exercise, analgesics, pain medication, spinal manipulation, and facet blocks. Education on proper posture and restoration of correct body mechanics is essential. Positions involving excessive extension or extension with rotation should be avoided. Strengthening the deep neck flexors and abdominal muscle can help balance the overactivated extensors of the neck and back. Spinal manipulation by using the muscle energy technique or high velocity, low amplitude maneuver to correct the type 2 dysfunction of the facet joints. Flexion rotation, side bend or extension rotation side bend postures can help to realign the facet joints and can alleviate pain. Research indicates that the C2-3 joint is the most commonly symptomatic level for cervical zygapophyseal joint pain, accounting for 36% of cases, followed closely by the C5-6 joint at 35%. Joints at C3-4, C4-5, and C1 2 were each symptomatic in less than 5%. On the posterior view, pain from C1, C2 most often occur in the suboccipital region. From there, it could extend cephalad to the occiput and vertex, or caudate into the neck. Pain from C1 to frequently occur over the vertex and in the upper forehead. C2-3 resemble that of C1, C2. It occurs anywhere within a band from the occiput to the vertex. C2-3 more often it extends over the lateral occiput toward the mastoid region and above, and across the parietal and upper temporal regions to end in the forehead or in the orbit. Pain originating from C3-4 level can manifest in the suboccipital and occipital regions, extend cranially to the vertex or forehead, or radiate caudally along the posterolateral neck. Pain from the C4-5 level tends to be focal, centered over the lower posterior quadrant of the neck. It can spread laterally into the uppermost and proximal region of the shoulder girdle and upwards to the suboccipital region. No patients with pain from C4-5 reported experiencing pain in the head. Pain from the C5-6 level typically centers at the junction of the base of the neck and the top of the shoulder girdle. It can extend cranially toward the suboccipital region, laterally across the outer margin of the shoulder girdle and arm, and less frequently it may spread inferiorly over the scapular region or into the posterior arm. No patients with pain originating from the C5-6 level reported experiencing head pain. Pain from the C6-7 level share a similar focal point with C5-6 at the junction of the neck and shoulder girdle, but differed in its spread direction. Typically, it extended inferiorly and medially into or around the central or medial aspect of the scapulae. No patient with C6-7 pain experience referred pain in the head. These distinctions enable the categorization of zygapophyseal joint pain into upper cervical and lower cervical distributions. I hope you enjoy this video. Please remember to subscribe for more content. Thank you very much again for watching.